Diolch yn fawr. Thank you. Diolch yn fawr. Bore da, good morning everybody. Thank you very much, Owen. Thank you, Helen. Really interesting to hear what you were discussing yesterday. I was really sorry not to be here. I was actually in London partly for the public inquiry, but things got better because I was at the NHS celebration in Westminster Abbey yesterday, and it was, I have to say, a fantastic event. It was one of those strange days in London where, you know, in London, I'm sure many of you will feel this, it feels sometimes like a place where every man is an island unto himself, but it wasn't like that at the event. Everyone was chatting and everyone was talking to each other. And there were some themes that really came out. And I didn't tell people who I was just kind of chatting to people, trying to be a bit of a mystery shopper. And generally, the feeling was that there's an immense pride in the NHS in what we have achieved and what we continue to achieve. But there's also deep, deep concern, of course, about where it's all going. But the other really interesting thing to me was that a lot of people, when they did find I was from Wales, they said, oh, fantastic, you have an integrated healthcare system in Wales, you're so lucky, we're trying to get there in England, we're trying to get there in Scotland, etc. So the point I suppose I took away from that was we should not discount the things that we are good at, and we tend to do that sometimes in Wales. We have a system which is never perfect, but we have the elements that we can build on. So it is the Bevan Commission conference, so we start with Nye Bevan, who got several mentions, of course, yesterday in Westminster Abbey. And the other kind of abiding thing which I picked up from the audience there was this massive support for the NHS and the massive concern about the way that the NHS is at the moment, the state of the NHS, but a deep, deep commitment from everybody to those founding principles, which I won't rehearse, I won't go over, but written throughout them. And I'm so glad, Helen, that you mentioned inequity, at the start, because written into the DNA of the NHS, as created by Bevan, is that principle of equity, treatment on the basis of need, not ability to pay. And those are fundamental tenets which I think were generally recognised yesterday. However, of course, there were some things which Bevan didn't and couldn't have predicted. He couldn't really have predicted the extent of demographic change 75 years later. The massive gains, the improvements we've made in life expectancy. We may, and I suppose we'll hear from Sir Michael shortly, we may have reached peak life expectancy at the moment too early, and there's reasons perhaps behind that we can discuss about. But nonetheless, that has brought with it some major challenges to our health system. Not least the increase in demand from frail elderly people, the increase in long-term conditions, the move towards multimorbidity away from acute infections, etc. So all of that is well known, but of course it brings a cost, and it brings a cost in terms of the percentage of our gross domestic product that is being spent and will need to be spent in the future on the healthcare system. So there's a big political challenge there. The second thing which Bevan couldn't have really predicted, and you can't blame him for that, would be the march of technology, the fact that the NHS can do more and more year on year and has more technology to do that. And that comes at a cost. There's a huge cost in terms of deploying that new technology, but it comes with the benefit, of course, of better patient outcomes. So we can do far more than we ever could do back in 1948. The other kind of dimensions, I think, which probably were not adequately factored in at the inception of the NHS was the massive growth in need for mental health services. And also some positive things, because if we look at what's happened over the COVID years, the move towards digital solutions and the innovative technology actually is part of our solution for the future. And the third thing, which perhaps wasn't as predicted, because people were coming in 1948 from a position of deep concern about what healthcare costs would fall on them and what that would mean for their lives, is the rising expectations and the assumption that the NHS will do and will deliver more. And of course, with rising expectations, which sometimes cannot be met, have not been met in recent years, there is a risk that satisfaction rates start to reduce. Now, I wanted just to talk about solutions, and Helen, encouraged me to this. And I'm going to talk about solutions. I'm going to talk quite a bit about the kind of public health. I'm a public health physician, so you'd expect me to do that. But I wanted to kind of talk about a healthier Wales, because that was the strategy that we established for ourselves here in Wales. You know, a few years ago now, 2018, it was established, and clearly it needs to be refreshed. But it did give us a route map as to how we could address the future. And of course, that was built on the parliamentary review that my predecessor, Ruth Hussey, led. And the Bevan Commission, of course, was deeply involved in that. So really, if we look at the bones of that and the things contained in that, the principles and the approaches that we outlined then, I think still remain valid today. The shift towards prevention, the shift from hospital care towards community care, the need to work across local health board boundaries, the need to work across the boundary between healthcare and social care. All of these things are as vital now as they have ever been. And we have to ask ourselves, well, why did we not proceed, as quickly as we had? And of course, we can blame Brexit, we can blame COVID for all of that. But we also have to look internally, I think, here in Wales and think about the inertia that we have in our system and how we address that inertia and get over that. Because the critical challenge now is to get on and deliver that route map, refresh it, but also deliver. So execution is really the important thing that we need to move on with. And yes, of course, we have some fantastic examples of where we have made progress. I talk to colleagues working in the eye care field, and I see the shift in the workforce, and some of the services from ophthalmologists into optometry. That's a fantastic shift. The same could be applied in dental care, and pharmacy is doing so much more now than it ever was. It's really stepped up to the mark. So there are great examples, but we need to industrialize those as ever. Now, I wanted just to focus on some of the constraints and some of the things which are getting in the way of a healthy Wales. And the first one, dead. Oh, there we go. The first one I wanted to focus on is the issue of frailty. We, as I say, the demographic change that Bevan couldn't have predicted is really upon us, and we have, a huge increase in the number of frail elderly people needing considerable care in our system. And our system is clearly not geared to meeting their needs at the moment. Just some figures, about half the population over the age of 45 experience frailty. The cost to the UK is estimated at £5.8 billion per year. And over 60% of our hospital beds at any given time are occupied by people experiencing frailty. And I suppose the irony in this is that hospitals are the very worst places for frail elderly people to be. They decompensate very, very quickly, and there's a real risk that frail elderly people stranded in hospital beds will never get back to their own home, which is the place they want to be, or back to the residential homes where they're being cared for effectively. And a corollary of all of this, of that 60% of beds being occupied by the frail elderly, is that our emergency care is backing up. And we see winter after winter increasing pressure on that system. And we have to have a system in Wales where the people who suffer from heart attacks or strokes have access to ambulances and access to care when they need it. So I think part of the solution here is to redesign our models. We currently have a model which is trying to do everything in one place, and we need almost 3 separate strands of work, whether it's streams of work or locations of work. We need to separate our urgent care from our planned care and the care of frail elderly people, which should be largely in the community. So that's a real challenge for us. So that's our first wicked problem. The second wicked problem really stems from that, and it's about the social care environment. And we clearly need a better social care settlement. We need a national social care system. We don't have that. We don't have that mirroring our NHS. We have made some progress in Wales. We've moved towards a living wage for people working in the care sector, but it's not enough. We have huge problems with workforce and attracting, retaining the workforce needed to support frail elderly people in their homes is a massive, massive challenge. And we also have a problem around the funding model for social care, which is clearly broken. It's frustrating to many of us, I know. It's 15 years ago now since the Dilnut report was looking at the funding of social care across the UK, and it made some really important recommendations to try and avoid catastrophic costs that were falling on people, to make sure that people paid a fair amount towards the living costs if they were in residential care, and that there was a nationally applied eligibility criteria. There was lots of really good content in there, but we haven't managed to implement that. And our challenge in Wales is to go back to some of those principles and start to implement them. There's a third wicked problem, and and it's around the NHS workforce. Now, we know that there's a huge problems around the workforce at the moment, and lack of many vacancies. About 1 in 17 people in Britain work in the health system, which is quite a remarkable thing. But there are about 1 in 11 posts are currently vacant. So we have massive numbers of vacancies. But I put this slide up just to remind us that year on year there has been growth in most areas of the NHS workforce. In fact, I think about 20,000 more people are employed in NHS Wales this year than were employed 10 years ago. So there is more, there are more staff, but there are not enough staff. The one exception, I think, is general practice, which I do worry. I was trained as a GP initially, and before I moved into public health, and I do worry about the capacity in general practice. But leaving that aside for the moment, we have an increase in capacity, but we're not meeting needs. So there is a real question running to the heart of our NHS about productivity and how much productivity we are able to achieve. And of course, overlying all of that is the current dissatisfaction that we're all aware of terms and conditions and people's living conditions. So the workforce is a major issue. There's another constraint, another wicked issue that we need to tackle. It's the IT of the... yeah, there we go. So it's the capital it's our infrastructure. It's clearly not fit for the current times. You know, there's a nice picture of CRI, the Royal Infirmary, many years ago, and how it is now. Not really radically changed. Of course, a lot of the services have moved out of there. But the reality, of course, is that some of our estate that we're using dates back to Victorian times. Much of it back to the 1970s, and our hospital. The legacy is really crumbling. There's a huge backlog in terms of maintenance. And it really is a deep analogy here, isn't there, with the water and sanitation. You know, we're reliant on Victorian sewerage systems. So we haven't invested sufficiently in our capital infrastructure. And we are now at a time where capital is not cheap and not likely to be cheap in the forthcoming years. So we need to think differently about how we attract capital, how we use capital. And we need to have a really deep debate, I think, with the public about the investment that is going to be needed if we're going to correct some of the historical underinvestment in the past. Of course, we are making some investment. You know, the Grange Hospital is our newest addition to the the infrastructure, and that's a great thing. We've invested, you know, money in other areas, £5 million in a radiotherapy satellite service up at Neville Hall, for example. 5.8 million pounds for renal unit in Morrison. So we are making some progress, but not sufficient, and there's a huge backlog that we need to address. The next thing I wanted to mention in terms of wicked problems it really relates to the public health agenda. This is Derek Wanless, who was, of course, was a banker, and I moved back into the UK public health system in just about 2000. And at that time, Derek Wanless was producing his report, Securing Good Health for the Whole Population. So that's, 20-odd years ago. And if you remember, he painted 3 different scenarios about how we could engage with the public and how things might go. And I might just read you some of those. But before I do that, you know, I am sometimes challenged as a public health doctor by colleagues, some of them who may be in this room, who say public health has failed. It has failed to deliver what it should have delivered. And I'm going to come back to that point in a moment. So the 3 scenarios, am I doing all right for time, Owain? Are we good for 5 more minutes, maybe? So Derek, I will then go through these. You know, he talked about 3 scenarios: the fully engaged, where people live longer and healthier, with a proportion of life spent in ill health actually declining, the public health improving, patients fully engaged, risk factors from smoking, obesity, lack of exercise, disappearing and disappearing more quickly in deprived areas. That was the fully engaged scenario, the most expensive scenario. In the middle was a solid progress where there would be an increase in life expectancy, but some of that would be spent in ill health, some of it in good health, and there would be some progress on reduced obesity levels, on better diets, reduced teenage pregnancy rates, etc. But with the gap in life expectancy falling by about 10% between the most deprived and the least deprived populations. And then the slow uptake was his final scenario, where he described life expectancy still continuing to rise. Note that it's probably stalled at the moment, but more of those years being spent in ill health. The uptake of technologies being relatively slow, productivity improvements not being realized, the quality of care being good still, but not offering a whole system integrated approach. And public health targets not being met. And I would argue that really, 20 years on, if we look back at all of that work and those scenarios, those predictions, we're probably closer to the slow uptake, if anything. So public health hasn't failed. It hasn't really been tried, and it hasn't been tried for a number of reasons, and that's partly political. The minister, I'm sure, will talk about some of that later. But also, and I feel this quite deeply, it's because the forces ranged against us are quite extreme. One of the great things I get to do as a CMO is to produce an independent annual report. And here's a selection of them over the last recent years. This year, I'm going to be focusing on the corporate determinants of health. And the reason I want to do that is because, if you go to Copenhagen or other European cities, you won't find a McDonald's on every corner of the street. And don't get me wrong, I'm not anti-McDonald's, but the reality is that in our towns and cities, we see McDonald's, we see KFC, we see Burger King, we see these everywhere, and you won't find that in other European cities. And it gets worse, because if you go to Mold in the north, or Caerphilly, or to Newport just down the road here, you have all of that, and then of course you have Betfreds and Ladbrokes with the gambling industry, and one of my reports there, Gambling with Our Health, focused very strongly on that. And now of course we have the rise of vaping shops. So these are the things you will see if you go into our cities. And I believe that our health is shaped to a large degree by our environment, and unless and until we're able to adequately start to think about how we address some of these concerns and whether it is possible to address these concerns, it will be very difficult to achieve those engaged scenarios that Derek Monmouth was talking about. Excuse me. And that requires, as I say, political will. Well, here in Wales, we have stable, long-term governments, so we should be able to mobilize our political will. But it also, and this is vitally important, requires deep engagement with our communities. And I think we should learn from the behavioral insight work we've done during COVID times to try to do that. So those are the challenges, I think, for the public health. Public hasn't failed, it's not been properly tried. So in conclusion, there's nothing really new under the sun. We've got the bones of what we need to do here in Wales. I'm sure you've heard some of those suggestions from yesterday. There'll be more coming forwards today. We know what we need to do. The NHS will survive. I am absolutely confident of that. It will survive, but it needs to transform, grow, and develop. And I would like to see public health at the absolute heart of that transformation. Thank you very much. Diolch yn fawr.